Hi, folks. I'm Dan Dworkis, and this is the Emergency Mind podcast, a place where we bring together lessons from the emergency department and beyond about performing at our best when it matters the most and applying knowledge under pressure. Now, you might have noticed that the show has been on a bit of a break lately. Not to worry, we'll be back soon with some great episodes. While we're getting all that set up, I'm happy to be able to share with you this epic discussion that originally took place during the 2024 Tactical Trauma event. If you have the chance to get to TAC Trauma in Sweden, you absolutely should. It's just an awesome event, and you can find out more at tacticaltrauma.se. What we're going to hear in this episode is a conversation around learning and excellence in high-performance teams. The first voice you'll hear is Ian Beardsell, followed by Abrehic O'Kelly, Alice Hutin, Stephen Hearns, and then eventually me. Before we get to the discussion, a reminder, if you want to connect with us at the Emergency Mind Project, we would love to hear from you. You can go to emergencymind.com, where you can reach out to me directly, dan@emergencymind.com. Okay, all that said, let's get into it. I hope you enjoy.
So what we've got now is something a little bit different. We're going to talk for half an hour about what teams are and what good looks like when it comes to teams. I don't know how you feel about today, but I've heard a lot of excellence, but I really want to work out how I can make that work for me in my department. I work in teams all the time of different sizes, whether that's pre-hospital, whether that's in the emergency department. And we're really lucky to have 4 people on stage who work with teams all the time in different environments. I'm sure you've met some of them already, but just to briefly introduce them, Abrehic O'Kelly, you see on the far side there, former Green Beret, tropical nurse and critical care paramedic who's heavily involved with the College of Remote and Offshore Medicine. Alice Hutin sitting next to him. She's an emergency physician with SAMU in Paris. I did a podcast recording with Alice yesterday, and she described her day-to-day job as, yes, I put people on EC. And I said, okay, what's your day-to-day job? I put people on ECPR. And I know, okay. You'll see Stephen, we met this morning, who's from Scotland's Air Ambulance Service. And also then we've got Dan Dworkis here. The main thing you'll hear from Dan is he has a voice like butter. It's quite something to listen to. So no matter what he says, you're going to enjoy how he says it. So you haven't even heard it yet. Just wait a minute. So I thought we'd just start off by thinking about what good looks like. And we all want to be in good teams, but we've all seen teams which don't go well. Abrehic, for you, in your post, in your role, you've been a Green Beret, you've been part of teams there. Clinically, you've been part of a team. What's a good team look like to you?
I guess a good way to describe this is comparing police and special forces. No, there's a lot of cops here, so don't get angry, or if you're armed especially. But in 1989, I started with the Sheriff's Academy in Southern California, and we went through the academy, and we were on the range shooting our service weapons, and we would fire until we got it right, and then we would stop, and that was the bet. That was that. Oh, we're got it good enough, and they actually let us go out on the street with a gun and a badge with that. And I thought that was the standard. I thought that was the elite. And I turned in my badge, joined the Army, became Special Forces, and we again went on the firing line. And I'm like, oh, I know this. And we fired our weapons until we got it right. And then we kept firing our weapons until we didn't get it wrong. And that's the difference between having a team together that trains together, that knows each other, and just doesn't get it wrong. And we can do this in medicine. So, for example, I'm a critical care paramedic. I'm in academia, so I haven't been on the rigs in ages. If, God help us, somebody here gives me a job where I've got to touch patients again, I'm going to train RSI again and again and again until I get it right. Brilliant. That's not good enough. I keep going and going and going until I don't get it wrong ever. And then put it on the floor, turn off the lights, but put them in a car restrained. We'll have to do the tomahawk technique. And in medicine, we can achieve the excellence that I saw in Special Forces by having that team, your team, train up to that level.
So training matters, and training with teams is really important. And having that is a bit of a luxury sometimes for some of us. Alice, we were talking yesterday about the work you do with SAMU when you have to go. You've got a patient in cardiac arrest and you're making decisions about whether you're going to put them on ECPR, ECMO or not. And that team may be made up of people you've never met before. So how do you go about getting everybody on board? We've said it before today, the shared mental model, and knowing that everybody's playing for the same goal and on the same team.
Well, it's really not something that easy because obviously there are everywhere for eCPR, mostly people who believe in eCPR and people who don't. So you sort of have to adapt to that concept as well, because sometimes you get to a scene where you know that the people are going to be waiting for you and waiting for you to put the patient under eCPR. And sometimes you go to some places where you know the mobile ICU team or the ALS team is actually not waiting for you to put the patient under eCPR because they've never really believed in it. They've never, seen a survivor. And so you have to adapt to that mood because it has happened to me, for example, that I got to a scene and the patient was a bit older than what we usually accept as a limit age. But the patient had signs of life through CPR. It had been 20, 25 minutes. And I was personally sure that that patient should have been treated with eCPR. But I got to a scene where the mobile ICU was actually going to stop CPR because they'd been through 20 minutes of CPR. They had no ROSC. And they thought, the patient was 70 years old. And basically they had, they'd gone through the sequence. And it was a very difficult moment for me because I was there. I had everything we needed to treat this patient with what we call a second line of therapy. And the team that was there was not okay with it. And in the end, I did not treat the patient because I could not go against the will of the initial treating team physician. But it's really something that's very difficult. And otherwise, and I mentioned this yesterday when we spoke, sometimes it's difficult getting to a scene where people are actually waiting for you to treat the patient. And in the end, once you've listened to the whole presentation of the case, everything that has happened, and you are there to say, well, no, this patient has no inclusion criteria, or there is no hope for neurologically intact survival, and we will not treat this patient with eCPR. So it's really adapting to all these different scenarios, scenes, moods, and energies that is something that's very interesting. And obviously, it's something that needs to be brought into the training of the physicians that we train to deal with eCPR. It's not just about cannulating. It's about dealing with all that. I'm not sure that answers the questions you asked me initially.
It may not have answered the question I asked, but it was certainly a question to an answer to a question, which was good. So we're sticking with it. Stephen, it's interesting, actually. Alice uses the term believers and non-believers. I'm not saying that doing pre-hospital emergency medicine is a religion, although I have worked with people who truly believe they are God. But when you get to a scene, there are people who you have to get on board, and you probably have tips and tricks. We can all practice the medicine, we can all drill the medicine, but you can't necessarily drill to how to talk to a paramedic who thinks that you're just an Oakley-wearing, big-headed idiot. How do you get those people on side? Have you got anything over your years of experience where you've had phrases you've used, other things to bring people on board, or to just sense, do you know what, I should just say nothing and that's better?
Yeah, so we talk about the concept of flash teams. Dan's going to talk about the concept, swarm teams. So that this idea that is absolutely part and parcel of what most of the people in this room do on a daily basis in an operational setting, where you may actually be buddied up with someone that you work with infrequently. You'll be deployed to a scene. There may be members of maybe 2, 3, 4 other emergency services, and you're thrown into that high pressure setting where you need to work collaboratively together to achieve things, but people are coming with different sets of knowledge and skills, the different mental model as to what's going on. They've got different objectives, maybe the fire service with extrication, the police with trying to preserve evidence, but you actually have to ensure at an early stage that people know who you are and what your objectives are, and try to get a shared mental model. And definitely, I think, in terms of working with ambulance crews when you arrive on scene, one is that you as an organisation to be doing your homework in advance and educating them as to what you actually do and what you can add to them to what they can do. But a big thing for us is to respect their territory. And when I worked in the London Air Ambulance 20 years ago, and one thing that I was taught was if you made a landing quite distant to the scene, absolutely run with all your stuff until you get to the last corner, and when you turn the corner, start walking, so that when you arrive, you're not out of breath, you're quite calm and in control. the patient is in the back of the ambulance, knock on the door of the ambulance and ask if you can come in when and you're basically being invited into their space. And the way you introduced that question there was, what do you say to the paramedics? I think the most important thing is not to really say anything, maybe just, how can I help you? And listen to them. So you're getting that sort of transition of ownership and that transition of care moving from them to you, and for them not to feel that you're a potential threat to them. Yeah. So yeah, that's what I would say.
I'm fascinated by the idea I could be a threat to anybody, but apart from maybe my children occasionally. Dan, we often work with high-performing individuals who somehow function in a low-performing team. And people might see that with their soccer team they support. I'm a Leeds United supporter, so I've had to live with this for many years. How do you get the best from high-performing individuals? We all expect that we're good team players. We're all above average, I think. If you asked 100 people, they'll say, oh, I'm definitely better than average. How do you take people who always believe they were better team players, but actually the team isn't working? Where do you go with those people?
Right. We're all very experienced mountaineers in this room, right? All of us. So I think one of the answers to that is to weave together a little bit of what we've heard up here, which is that teamwork is a skill and teaming is a skill, and being a member of a team is a separate skill than doing your other skills. And it's a skill that you have to train and sort of work on. And I think one of the things that we know about that is that you have to see it at its best to know what you're aiming at, right? To actually understand what you're aiming at. So, Eric was talking about the idea that we thought this was the standard until we saw a higher standard, right? Or we come across teams that maybe don't believe in what we do because they haven't seen it, right? Or, sometimes you get a friend and a mentor and you believe so much in them that you dress exactly like them and have the same haircut, right? Because you understand what excellence looks like, right? And so it really, are we pausing when there are excellent teams where the teams come together and saying, hey, this is what we should be aiming at, right? This is what we should be aiming at. Are we talking not just about the technical skill, but about the teaming skill and the interpersonal skill? Like when we're debriefing, and you're coming back from a run, are you talking to your teammates, not just about did you intubate, but hey, can we talk for a minute about how you spoke to the person in the ambulance and how you made that approach? Because those skills are what make a difference in there. And I think the first answer is you have to talk about it. You have to, because I actually do think you can train on teaming as a skill, whether or not it's in what we would call, and I'll talk about this more later, but an intact team where you train to be on the team and you perform with that team, or something more like a smash team where you're taking two sets of experts and banging them into each other to try to get something done. Either way, you can train that skill of teaming.
We all know that learning is a long journey. We see it on X Factor all the time. We're all going to go on a journey, and you guys have all reached a point in your journey where I think I've not had the pleasure of working with any of you, but I'm sure you're all good team members. I just wondered, do you ever reflect back on times you weren't good members of the team? Because what we see now in front of us is excellence, but can, for want of a better term, mere human beings become excellent? We've all had moments. Have you had moments where you thought, I could have done that better?
Right. I'll keep going because I have this. Absolutely.
You've got the microphone. You can do what you like.
Right. I have two microphones. I mean, there are certainly times when you don't perform up to the level of how you want to be as part of a team, right? In the same way that there are times when your technical skill isn't at the level that you want it to be at. And what do you do about that? You go back and you train more, right? The same way that if your technical skill wasn't where you wanted it to be, then you'd go back and train more. You don't think that ability to team as a verb is any more a set characteristic of who you are as a human being than your ability to intubate is. If you can train one, you can train the other, right? Jokes aside, and I'm not going to make this political, but jokes aside about not, being an American that hogs too much, I hope that we can evolve, right? In terms of how we are teammates to the world. And I think that we have some strength in that and some weakness in that and some ability to improve in that. But I don't think that's any more a set characteristic than any other skill that we have is. At least I hope that's true when I look back at times when I haven't lived up to what I think the best teammate could be.
Let's imagine that it's been highlighted to me that I'm a poor team player and I need to go and work on my team membership skills. How would I go about becoming a better member of a team? What can I do personally for myself about self-improvement to become better at being a team member?
Softball questions. Looking back on excellent teams, I've been in many excellent teams. I've been the weakest link on excellent teams. I've been in medium of excellent teams. And there's an NCO creed in the U.S. Army. It's called Know Yourself and Seek Self-Improvement. To know where you are within the team and then always try to be better. So I remember first day on the Special Forces team. So I get through selection, which wasn't as hard as the SES one. I'll be the first one to say that. And then the Q course. And then, I'm on the team. Great. And then the team stopped. So whenever a new guy comes onto a Green Beret team, the team goes offline for about a month to train up because I'm the weakest link, aren't I? So we have to go out on the range and make sure that everyone's on the same team, so everything I got in the Q course was copacetic and then going out, I was on a maritime, so it was all about boats. And so being the weakest link, I think I know what a boat is, but now I'm supposed to be the best of the best on the boat. So the train up. So anytime in medicine, anytime you have a new team member coming in, someone just after nursing school, great. He's a nurse. Brilliant. We know where that is. How is he working within the team? And sometimes it does take some offline, taking the team offline and discussing roles and running through scenarios and then being honest. In Special Forces, the first time somebody comes up and bullshits, he's off the team. You have to be completely, and you raise your hand. I've never shot an MP5. How do we do that? And be very honest with that. And as leaders, there's a lot of leaders in here. You need to incorporate this into your team of know yourself and continue your self-improvement and help that. And don't be a dick. Don't come in and say, well, I'm a consultant, whatever, and I know what's best. Come in and say, I'm a consultant and I actually haven't done A&E for ages, and how about this senior house officer who I far outrank would be like, hey, how about you walk me through this procedure because it's been a while. So
we talk a lot about leadership, and some of the talk titles have the word leadership in them, but you've just described what I think Kevin was mentioning earlier today about rank versus role. Rank and role are two very different things, and your rank doesn't define what you do on a given day. I'm really keen to know how to be a better follower. Alice, what could I do if I was coming to work with you on the streets of Paris to be a good follower, despite the fact that I want everyone to listen to my voice, laugh at my jokes, and think I'm the best person here? How could I change that to be a good follower?
That's a tough question. I don't know. I don't think it's important to be a good follower. I mean, it's important to be part of the team and to be, taking part of the decision making, part of the action. And I mean, following is I don't really relate to the term, I guess. I think it's really important to incorporate people in the team. And I was actually at lunch discussing this with some of you guys. In our team, it's very easy because we're a small team with 3 people, and when everything works well, everyone knows exactly what they're supposed to do. And then when you have a new person on the team, as you were saying, everything everything can blow up because you've not taken the time to incorporate the person, maybe not as a follower, but as a new team member, and you expect them to do all these things that you haven't, helped them bring into their mindset or into the what they're supposed to do when you go actually into the action of putting a patient under ECPR. So I think it's more about being actors, and all the whole team members need to be actors more than followers.
Stephen, did you want to come in?
Yeah, my mum used to say the gift of God to give is to see ourselves as others see us. I can translate that. People are much more likely to have insight into their own behaviours and to make change if they can actually see themselves and how they come across with implicit communication as well as explicit communication. And the reason I get interested in this maybe 10 years ago is because our service got ethical approval to start wearing body cameras. And it was limited to emergency anaesthesia procedures that we were undertaking pre-hospital and in small rural hospitals. So dead simple, you probably use them as well. But the paramedic nurse, the registrar that was working with me would be audio recording me, would be filming me, and vice versa. And we'd go back and we'd use that as a debrief, partly to say, right, how do we rationalise our equipment? How do we improve our procedures? But big thing for that was I am really variable in my performance in terms of clinical decision making and leadership. And sometimes I'm extremely good in high pressure situations, and I'm really good at making the decisions, leading the team, carrying out the tasks. But if that patient is not doing what I think they should be doing, it is written all over my face, and I am a blamer. There's no way that I had insight into this before. And my name's Hearns, and it turns out that all the nurses and the paramedics had a look that I could give them, and they talked about being herniated. It's just a way that I could look at people. So that was hugely insightful for me to realise. You go back and you debrief, now I said this, you said that, but actually so much of it is about your facial expression, your posture, what your hands are doing, and particularly how you're looking at individuals. And there's so much to be gained from that, looking at your own personal behaviours and how you're interacting with other people. So body camera filming, simulation, great, but actually operationally using it as a tool for that is hugely powerful.
We, I think, in many of the countries who are represented here, live in really stretched emergency care systems. And it's a bit disappointing for me in the UK to think, I could go and work somewhere else and it would be better. And then I talk to people and it turns out, no, it's exactly the same. And we do spend a lot of time saying, isn't it difficult? Isn't it hard? Just for the last few minutes, Dan, starting with you, I'd like you to just imagine you have an open book. You're not limited by time. You've got a chief executive who's listening to you. You've got people who are engaged with what you want to do. And you have a 3-minute elevator pitch to make to those people to convince them of what you want to do to make teamwork, wherever you might work in the hospital, pre-hospital environment, better. Normally, obviously, we'd give you a couple of days to prepare for this. I'm giving you approximately 30 seconds. But what would your elevator pitch be in that world where we could make things better?
When I was an intern, it was my first year of being an ER doctor, and we got to rotate through the other areas. I was at Mass General, and I rotated in the ICU. And there was a face sheet up on the wall of who was in the ICU that day, right? So there was the senior doctor that had their picture, the junior doctor that had their picture, and then there was a space where my picture would have been, but it was blank, and it just said ER intern, right? Because from the point of view of that part of the hospital, ER doctors were interchangeable and not real people, right? And so over the course of that several weeks in there, I don't know if anybody else has ever felt like that, right? But, we sort of I drew a picture for myself on there. The point of that story is that from lots of points of view of the hospital, lots of people don't belong. And I think that we need to go back and tackle that. We need to have a space where everybody who's part of the team understands that they are part of the team and belongs on that team and sees themselves sitting on the same side of the table, working that complex adaptive problem together, as opposed to facing it down from opposite points of view and competing with each other. Proximal root thing I would fix is that sense of who we are. And I would make sure that we have the ability to actually believe we're on the same side of the problem, working it together. That's quite hard. We come from different training backgrounds and different styles of thought. And that tribalism is baked into us pretty early in our training. So you'd have to have not just a CEO that was listening, but also med schools that were listening and sort of the things behind that. But that's where I would start for it.
You start there, Alice. Where would you go next? What would you say to the head of SAMU? Obviously, if you could just say it in English and not French, that would be convenient for me. But what would you say to them about what you would have in the golden vision of how you could look after your team?
Well, it's a bit difficult for me to actually answer that question because we actually changed our head of SAMU director a few months now, a year ago almost. And Professor Kelly, who some of you might have known or heard about, was a very supportive leader of ECPR. And recently, the new chief is less of a believer, I would say. And it has sort of created some kind of instability in the fact that we had this whole procedure that was lined out where we would be dispatched early, as I mentioned yesterday, for those of you who were at the workshop. We would get to the scene early, decide on ECPR, and everything was very lined out, organized, and nothing was left, to interpretation. And this new chief, although he's not, saying don't do ECPR, has left some kind of space for uncertainty and people thinking, well, maybe we can wait for ECPR. Maybe we don't have to dispatch them early. Maybe we can just, see how things go. And it's sort of making things very difficult at the time. And it's very unstable. So I would say, try to keep things on a straight road. And it's really about thinking about the patient in the end and organizing things to treat the patient in the best way possible and stay to procedures, I guess.
The best thing about this conference is that these conversations can continue, and you can have conversations with the people on the stage and with each other and think a little bit more about what Teams means to you and how you're going to be a good team member, a good team leader, and we can make our teams better. We've run out of time very sadly, but would you all give a round of applause to Abrehic, Stephen, Dan and Alice?